Before we move on, I want to quickly share something that could really help you. You can now join our online NCLEX crash course, specially designed to help you pass the NCLEX on your very first try. This program has already helped over 1 lakh nursing students clear the exam successfully. And now, it's your turn. And here's the exciting part. We're giving a limited time 70% discount on the course fee. But remember, this offer is only for a short period, and seats are filling up fast, so don't wait too long. To enroll, just download our mobile app. You'll find the link in the description box below, or you can scan the QR code you see on your screen. This NCLEX crash course is truly a one-stop solution. It's a proven shortcut that helps you study smart and pass with confidence. So don't wait. Enroll now and stay ahead of thousands of other students in the race to pass the NCLEX. And yes, if you'd like some free PDF notes for NCLEX questions and a free NCLEX ebook, just download the mobile app. You'll get instant access to all those materials right away. All right, let's get back to learning. Here comes the next question.
Hello, my dedicated nursing learners. Every day, we cover 2 to 3 core NCLEX topics designed to sharpen your clinical judgment and boost your exam confidence. And today's topic is one of the most critical in understanding the body's delicate balance between bleeding and clotting. Today, we'll be diving into nursing care of clients with coagulation disorders, a vital area that includes conditions such as hemophilia, disseminated intravascular coagulation, DIC, thrombocytopenia, and von Willebrand disease. These disorders challenge the nurse's ability to recognize subtle warning signs and respond swiftly to prevent life-threatening complications. In this session, you'll learn how coagulation disorders develop, how they affect the clotting cascade, and how to interpret key lab findings such as PT, APTT, international normalized ratio, and platelet counts. We'll also explore nursing priorities like bleeding precautions, transfusion protocols, medication safety, and client education on avoiding trauma and using prescribed therapies such as factor replacement or anticoagulants correctly. By the end of this class, you'll be confident in identifying red flags like spontaneous bleeding, petechiae, or prolonged clotting times. And you'll know exactly which nursing interventions save lives in emergencies like DIC or massive hemorrhage. Before we dive into session, hold on a second before we dive into the next NCLEX topic. I need to share something urgent with you. If you are serious about passing the NCLEX on your very next attempt, you cannot afford to miss the ultimate NCLEX crash course. More than 100,000 students have already cleared their exam with it, and you can too. Why is this course different? Because it gives you everything in one place. Live interactive classes, recorded lectures you can re-watch anytime, 5,000 practice-style questions, 30 practice tests, eBooks and PDF revision notes, a student planner, and detailed NGN question explanations. This is your shortcut to success. Don't wait. Scan the QR code or click the link in the description now. You will instantly unlock free study content, including NCLEX quizzes, PDF notes, and practice tests, plus access to our Telegram and WhatsApp groups with even more support. Let us now move into another essential hematologic concept that every nurse must confidently recognize in both clinical practice and the NCLEX exam setting. A nurse is assessing a client who has recently been diagnosed with idiopathic thrombocytopenic purpura, also known as ITP. The question asks, based on this diagnosis, which physical finding should the nurse expect to observe during assessment? Here are the options to consider. Option A is small skin hemorrhages. Option B refers to dark areas of. Option C states flushed red skin. And option D mentions protruding veins. The correct answer is option A, small skin hemorrhages. Idiopathic thrombocytopenic purpura is an autoimmune hematologic disorder characterized by isolated thrombocytopenia, in which platelet counts drop below the normal threshold of 150,000 per cubic millimeter, often plummeting below 20,000 in severe cases. This occurs when the immune system produces autoantibodies, primarily immunoglobulin G, that bind to platelet membranes, marking them for destruction by the spleen and liver. Because platelets are vital for primary hemostasis, their deficiency causes fragile capillaries and widespread microvascular bleeding. During physical examination, the nurse should expect to observe petechiae, which are tiny pinpoint red or purple spots, along with purpura, which are larger flat discolorations, and ecchymoses, which are bruised areas. These are classic indicators of bleeding into the skin and mucous membranes due to the absence of platelet plugs. Clients may also exhibit spontaneous nosebleeds, bleeding gums, hematuria, or melena. In female clients, heavy menstrual bleeding is common. The most severe danger is intracranial hemorrhage, which manifests as headache, confusion, or neurological changes, a true emergency requiring immediate intervention. Laboratory results typically confirm isolated thrombocytopenia with normal coagulation profiles, meaning prothrombin time and activated partial thromboplastin time remain unaffected. This distinction confirms that bleeding results from platelet loss rather than clotting factor abnormalities. Bone marrow aspiration may reveal increased megakaryocytes, indicating compensatory platelet production. From a nursing standpoint, the focus is strict prevention of bleeding and injury. Nurses must institute bleeding precautions, such as avoiding intramuscular injections, using soft toothbrushes, avoiding non-steroidal anti-inflammatory drugs and aspirin, and regularly assessing for occult bleeding. In cases of active bleeding, platelet transfusions may be necessary. Corticosteroids and intravenous immunoglobulins help suppress immune-mediated destruction, while splenectomy may be considered for chronic or refractory ITP. Moving on to why the other options are incorrect. Option B, dark areas of cyanosis, is incorrect because cyanosis results from poor oxygenation or hypoxia rather than platelet deficiency. It is a sign of cardiopulmonary compromise, not a bleeding disorder. Option C, flushed red skin, is also incorrect since erythema and warmth occur in inflammatory or febrile states, not due to thrombocytopenia. Lastly, option D, protruding veins, indicates venous insufficiency or increased venous pressure, which is unrelated to platelet malfunction or bleeding tendencies. Moving forward to an insightful perspective, Stancoast Clinical Insight. In idiopathic thrombocytopenic purpura, every red or purple dot on the skin tells a story of capillary rupture and platelet failure. Early recognition of petechiae and purpura can prevent catastrophic internal bleeding. Finally, turning to a high-yield exam takeaway, Stancoast High-Yield NCLEX Pearl. Always remember this key cue: low platelets equals leaky capillaries. In ITP, mucocutaneous bleeding such as gum bleeding or petechiae appears first and serves as the earliest visible warning sign of a developing hemorrhagic crisis. Let us now move into a high-level nursing scenario that highlights critical thinking in hematologic care. During interdisciplinary care planning, the nursing team discusses priorities for a client diagnosed with severe thrombocytopenia secondary to chemotherapy. The question asks, which nursing intervention should receive the highest priority in the plan of care? The available options are as follows. Option A suggests encouraging oral fluid intake to maintain hydration. Option B proposes promoting ambulation and range of motion exercises. Option C recommends restricting visitors to prevent infection. Option D advises implementing safety measures to prevent injury. The correct answer is Option D. Implement safety measures to prevent injury. Thrombocytopenia refers to an abnormally low platelet count, generally below 150,000 per cubic millimeter, and in severe cases may fall below 20,000 per cubic millimeter, placing the client at extreme risk for spontaneous bleeding. Platelets are indispensable in the early phase of hemostasis because they form the initial platelet plug that seals microvascular injuries. When platelet counts plummet, even minor trauma such as brushing the teeth with a hard toothbrush, bumping a bedside rail, or administering an intramuscular injection can precipitate life-threatening hemorrhage. Therefore, the foremost nursing goal is to prevent injury through meticulous safety precautions. The care plan should include padding side rails, avoiding rectal temperatures or suppositories, using a soft toothbrush or sponge for oral care, avoiding intramuscular injections, and applying prolonged pressure after any venipuncture or intravenous procedure. Activity should be cautiously limited to reduce fall risk and tissue trauma. Vigilant observation for petechiae, ecchymosis, gum bleeding, hematuria, or headaches, potential indicators of intracranial bleeding, is vital. Nurses should educate clients to immediately report headaches, visual changes, or confusion, as these may signal cerebral hemorrhage requiring emergency action. Moving on to the incorrect responses. Option A, encouraging fluids, though beneficial for maintaining circulation and renal perfusion, does not mitigate the central threat of bleeding in thrombocytopenia. It becomes a secondary priority unless dehydration or hypovolemia coexists. Option B, promoting activity, is inappropriate for severe thrombocytopenia because movement or exertion can increase the likelihood of falls and bruises. Controlled rest and gentle repositioning are safer until the platelet count recovers. Option C, restricting visitors, may help in neutropenia, but not in thrombocytopenia. These clients are at risk for bleeding rather than infection, making this intervention irrelevant to the primary concern. Now turning to the Stancoast clinical insight. In thrombocytopenia, every bruise tells a story the nurse must hear before it bleeds louder. Preventing the injury is not just a safety goal, it is a life-saving intervention. And transitioning into the Stancoast high-yield NCLEX Pearl, always verify platelet count before performing invasive procedures or administering medications. Hold anticoagulants, avoid intramuscular injections, and handle the client with gentle, deliberate movements. Remember this golden principle. Low platelets equals leaky capillaries. Let us now move into an essential hematologic emergency scenario that highlights critical nursing judgment. A client diagnosed with hemophilia A sustains a minor closed head injury after slipping in the bathroom. Before discharge, the nurse provides detailed education regarding early warning signs of intracranial hemorrhage. The question asks, which client statement best demonstrates correct understanding of these discharge instructions? Here are the options. Option A states, if I start having seizures, I should call the nurse immediately. Option B says, if I feel unusually sleepy or drowsy, I need to seek help right away. Option C mentions, if I hear ringing in my ears, it probably means I hit my head too hard. And option D adds, if I lose my appetite for a day or two, I should return to the hospital. The correct answer is option B. If I feel unusually sleepy or drowsy, I need to seek help right away. Now, let us explore the reasoning behind this. Hemophilia is an X-linked recessive genetic disorder caused by a deficiency of essential clotting factors, most commonly factor 8 in hemophilia A and factor 9 in hemophilia B. These clotting factors play a key role in the intrinsic pathway of the coagulation cascade. Their absence or deficiency results in delayed clot formation, which predisposes the individual to prolonged bleeding even after minor trauma. Among the most critical complications is spontaneous or trauma-induced intracranial hemorrhage, which can be fatal if unrecognized. Following a closed head injury, the earliest and most sensitive sign of intracranial bleeding is a subtle change in the level of consciousness. This can appear as drowsiness, lethargy, irritability, or confusion. These symptoms arise because even a small amount of bleeding can increase intracranial pressure, compressing brain tissue and impairing perfusion. As the pressure builds, more severe signs follow, such as persistent headache, vomiting, blurred vision, unequal pupils, weakness, and later seizures or coma. Prompt identification and administration of Factor VIII, replacement or recombinant anti-hemophilic factor, can prevent permanent neurological damage or death. Nurses must reinforce that in clients with hemophilia, any change in alertness, no matter how mild, should be treated as an emergency. Now let us examine why the other options are incorrect. Option A, which mentions seizures, reflects a late sign of intracranial hemorrhage. Waiting until this occurs could delay urgent intervention. Option C, ringing in the ears or tinnitus, is not related to intracranial bleeding. It is more often linked to ear infections, ototoxic medications, or pressure changes in the ear. Option D, which focuses on loss of appetite, is nonspecific and unrelated to neurological bleeding. Though nausea and vomiting may accompany raised intracranial pressure, loss of appetite alone is not a reliable early indicator. Transitioning to our next key insight, we move into the deeper learning point every nurse must internalize. Transitioning to a deeper insight into clinical reasoning, Stancoast. Clinical insight: in hemophilia, a bruise on the outside can heal, but a bleed inside the brain can steal a life silently. The first yawn, the first nap, or the first "I feel sleepy" after a head injury may be the only warning. Never ignore it. And now moving into the Stancoast High-Yield NCLEX Pearl. Always instruct clients with bleeding disorders that any head injury, no matter how trivial, is a medical emergency. The priority nursing actions include closely monitoring for even minor changes in level of consciousness, promptly administering Factor VIII or IX concentrates when bleeding is suspected, avoiding aspirin, non-steroidal anti-inflammatory drugs, and intramuscular injections, and ensuring that clients wear medical alert identification that specifies their hemophilia type and required factor.